Which of the following is the most common cause of dilated cardiomyopathy? Idiopathic. B. Systemic lupus erythematosus, SLE. C. Tuberculosis, TB. D. Cocaine. E. Familial. A. Idiopathic. Dilated cardiomyopathy is most commonly idiopathic. Viral myocarditis, chronic alcohol use, Chagas disease, and certain chemotherapeutic agents, doxorubicin, daunorubicin, may also predispose to dilated cardiomyopathy. Tuberculous myocarditis, connective tissue disease, and familial disease are less common etiologies. Cocaine usually causes hypertrophic cardiomyopathy. A 7-year-old girl presents with syncope without a prodrome. EKG shows QT prolongation. Family history is most likely to reveal which of the following? Cystic fibrosis. B. Hirschsprung's disease. C. Juvenile rheumatoid arthritis. D. Deafness. E. Short stature. D. Deafness. Prolongation of the QT interval may be due to congenital or acquired causes. Congenital long QT syndromes may be associated with deafness, Jervell-Lange-Nielsen syndrome, or without deafness, Romano-Ward syndrome. Acquired causes can be from electrolyte abnormalities, environmental conditions, or medication effects. Excessive prolongation can result in potentially fatal ventricular dysrhythmias, such as ventricular fibrillation and Torsades D points. Treatment is usually with magnesium and standard advanced cardiac life support (ACLS) protocols. Prevention of ventricular dysrhythmias is with chronic beta blocker therapy and sometimes pacemakers defibrillators. Which of the following is true with respect to carditis caused by Lyme disease? Patients most commonly experience initial symptoms several years after the initial tick bite. B. Patients most commonly present with variable degrees of atrioventricular AV block. C. Patients most commonly suffer from symptoms of CHF. D. The prognosis of patients with Lyme carditis is poor, as almost 1/3 of patients ultimately require a heart transplant. E. Most patients are seronegative for anti-Borrelia antibodies at the time of presentation. B. Patients most commonly present with variable degrees of atrioventricular AV block. Carditis complicates approximately 5% of untreated patients with Lyme disease and more commonly affects men. Cardiac manifestations occur during the early phase of the illness, typically within a few weeks to a few months of infection. The most common manifestation is AV block of varying degrees. Patients with a PR interval 300 milliseconds are at highest risk for progressing to complete heart block. Occasionally, patients require permanent or temporary pacemakers. However, most patients recover quickly without sequelae within 1 to a few weeks. Occasionally, patients have persistent first-degree heart block. Patients less commonly suffer from myopericarditis and symptoms of CHF. When present, myopericarditis is typically asymptomatic and not clinically relevant. Overall, the prognosis for patients with Lyme carditis is very good. The diagnosis is made when patients with appropriate findings give a history of tick exposure or have positive antibody tests. While patients with early localized Lyme disease can have false negative antibody, most patients with Lyme carditis are seropositive. A 56-year-old man with long-standing hypertension and mild renal insufficiency presents to the ED with vague complaints of fatigue and generalized malaise. His EKG is shown. Which of the following is the next best step in management of this patient? A. Nebulized albuterol. B. Insulin. C. Calcium chloride. D. Sodium polystyrene sulfate, Kaiglate. E. Furosemide. C. Calcium chloride. Answer C. This EKG reveals changes consistent with hyperkalemia. Cardiac arrhythmias are the most serious consequence of hyperkalemia, and the presence of EKG changes mandates emergent therapy. This patient's EKG demonstrates peaked T waves, which are among the early EKG changes in the setting of hyperkalemia, typically occurring at levels above 6.5 MEq per L. In general, hyperkalemia decreases cardiac excitability resulting in flattened P waves, a prolonged PR interval, and a widened QRS interval. Although all the agents listed are beneficial in patients with hyperkalemia, calcium is the agent of choice as it has a rapid onset of action, 1 to 3 minutes, and stabilize myocardial membranes. Calcium gluconate or calcium chloride may be given, but calcium chloride provides 3 times the amount of elemental calcium per unit dose. However, calcium chloride may cause tissue necrosis upon extravasation from intravenous lines and is irritating to local veins. Therefore, most authors recommend that calcium chloride is delivered through a large-bore central venous catheter. Among patients presenting with MRCEM, which of the following describes the appropriate use of antiplatelet therapy? A. Aspirin alone, given in doses of 162 to 325 milligrams, is the standard of care. B. Aspirin plus a GPBA inhibitor should be given in all cases. C. Either clopidogrel or a GPBA inhibitor should be used in addition to aspirin. D. Patients should only receive clopidogrel in addition to aspirin if no percutaneous intervention, PCI, is planned. E. Clopidogrel is only indicated for patients who are intolerant of aspirin. C. Either clopidogrel or a GPBA inhibitor should be used in addition to aspirin. Answer C. Dual antiplatelet therapy is the recommended approach in patients with MRCEM. Upon arrival to the ED, all patients should be given between 162 and 325 milligrams of uncoated aspirin to be chewed immediately. Uncoated aspirin is preferred over enteric-coated aspirin because of its more rapid absorption. At these doses, aspirin nearly immediately, completely, and permanently, until a new platelet is made, inhibits thromboxane A2 production, which is critical for platelet aggregation. In addition to aspirin, patients should receive either clopidogrel, ethynopyridine, along with ticlopidine and prasugrel, or a GPBA inhibitor, such as abciximab, eptifibatide, or tirofiban. Most guidelines recommend clopidogrel as the first-line agent in patients being managed without PCI, while clopidogrel or a GPBA inhibitor can be used in patients subjected to an invasive strategy. While some studies have suggested that higher loading doses should be used, the recommended loading dose of clopidogrel in the setting of MRCEM remains 300 mg unless immediate catheterization is going to be performed, in which case the recommended dose is 600 milligrams.